Thank you very much. So just disclosures, a consultant for GE and Terumo, and then as he says, I kind of have a unique perspective with both being boarded in radiology and urology. And really my goal today was to give you an overview of what I think imaging and intervention exists right now within urology and kind of where future directions of it go. It's a fairly broad topic, and I thought the best way to do it would just be to go over kind of 10 cases that I typically see in clinic and that I'm usually involved with at Cornell. With the exception, I'm not talking about varicocele embolization because you guys have the expert here with McCann. So the first cases are within prostate. What we'll discuss is imaging of prostate, particularly as it pertains to multiparametric MRI. Briefly touch upon focal therapy, and then also discuss prostate embolization. And then in kidney, we'll just briefly touch upon renal biopsy, renal ablation, and then embolization as well. With regards to the first case, this was a 72-year-old gentleman who presented to me with a rising PSA. His PSA had been around 2 to 3 for several years, and then over the past year it jumped up to about 8. He had never had a prior biopsy and presented with this T2 hypointense left peripheral lesion with restricted diffusion, which correlated with a PIRADS 4 lesion. So we discussed the risks and benefits of biopsy. He was healthy. We thought it was warranted. So we proceeded with a transperineal targeted biopsy as well as a systemic biopsy. And what we found was a grade group 3 prostate cancer. He elected to undergo radiation therapy. And this case I just am using to highlight kind of the benefits of what multiparametric MRI can show us. And basically multiparametric MRI shows us the anatomy of the prostate with T1 and T2 weighted imaging, and then also gives us functional components of the prostate, looking at restricted diffusion with DWI and ADC, as well as contrast enhancement. When we look at lesions that we see on MRI, we know that they're histologically distinct. We tend to see lesions that are greater than a centimeter. We tend to see higher grade prostate cancer, Gleason score at least 7 or greater, and also lesions that tend to have a solid tumor growth pattern. And then if you look at MRI with Final Pathology, Rob Ryder's group showed this in about 122 patients. They looked at patients who had had a preoperative MRI and then a subsequent prostatectomy. What they found in these 122 patients, there were 283 foci of prostate cancer, just highlighting the fact that prostate cancer is a multifocal disease, but identified the majority of prostate cancer that was seen was greater than a Gleason 6. Most Gleason 6 was missed. And then with looking at index lesions, which is the dominant lesion, usually a Gleason 7 or greater and a lesion size bigger than a centimeter, about 80% of those tumors were also identified on Final Pathology. So the second case, this was a 73-year-old male with a rising PSA, not significant, 3.4 to 4.3 after 18 months. His prostate was enlarged moderately at 45 grams and his PSA density was 0.9. His PIRADS lesion was a 3. So based on this information, how many would proceed with a biopsy? No one would. We're going to do a biopsy, okay. So if you go off of the Precision trial, which was a randomized controlled trial looking at the utility of an MR-targeted biopsy compared to just simple systemic biopsy, they showed that using MR fusion and MR-targeted, you had an increased incidence of detecting clinically significant prostate cancer. So he, based on odds, would be a 12% risk potentially of finding some clinically significant prostate cancer. So after discussion with them, this is usually how I talk to patients about this, if they have a PIRADS 3 or PIRADS 2, that you have about a 20 to 10% chance of missing a prostate cancer. He did elect to proceed with a biopsy. So we went ahead and do a biopsy. It's a busy slide, but basically it's busy because he has high volume, high risk prostate cancer. So this case really highlights the fact that prostate cancer can be missed, and clinically significant prostate cancer can be missed. This is Rob Ryder's group again, which this year updated their RadPath data. And here they looked at almost 600 patients. And what they found is that looking at Gleason score lesions, if 40% of Gleason score 3+4 were missed, and up to 22% of Gleason score greater than 8 were missed. And when looking at index lesions, up to 30% were missed. So I think it just highlights that we have to be really careful with multiparametric MRI. And this is coming from like a leading academic institution on MR, and having experienced some MRs in the other parts of the country where you get referrals, and the MR, the radiologists don't necessarily have the same training. So before MRI really becomes widely adapted, we really have to be cognizant of the fact that MRI does miss clinically significant prostate cancer. Other things it misses, this was from Lenny Mark's group. He was looking at the MRI detecting lesion size, and the reason why this is important is because you want to think about this: what you see, do you need to treat it the same way as a kidney ablation? So with a renal mass, it's very easy to see where that is. It's very easy to see where the mass is to do the ablation. And they looked at whether or not the MRI correlated with the size, and what they found was that the prostate MRI underestimates lesion size by about a centimeter in all directions. So if you're doing an ablation on a prostate based off the MRI, you need to have a good solid margin, similar to cryoablation with kidney. The future prostate MRI, there's a lot of interest now in doing non-contrast sequence because there's concern over gadolinium, such as RSI and DTI. Hopefully there's been a couple studies that have suggested this increases the area under curve in detecting prostate cancer. And then there's also some interest in radiogenomics. This looked at the gene expression in lesions that were seen on MRI versus lesions that were not seen in MRI. As you can see, there's an increased risk of gene expression in some specific genes with lesions that you can see on MRI versus those that you cannot. So I think for multiparametric MRI, there's going to be a lot of moving forward. There'll be future studies looking at non-contrast imaging, particularly DTI, RSI. I also think that there may be some change with regards to the PIRADS lesion. When reporting PIRADS, there's some limitations to it. For example, you could have a very small focus of highly restricted diffusion, but it's not really it will get bumped down to a PIRADS 4 as opposed to a 5. So I think there's some limitations with PIRADS, and at the AUA there was a poster suggesting there's a better grading system. Also, MRI is not available to everyone, and I think that when you're looking at limited resources, we need to figure out ways to better evaluate the prostate, and multiparametric ultrasound, I think, is a future for that, as well as high-frequency ultrasound as well. And then molecular imaging with PSMA, for example, there may be a role for that in localized disease as well. We do it at Cornell for looking at metastatic disease, and these are just two cases where we've have enrolled patients in our trial and shown some benefit to it. So this was a 59-year-old male who had a surgery in 2014 for a Gleason 7 T3B prostate cancer. He underwent radiation in 2016 because he had biochemical recurrence, and at the time of surgery he had a small positive surgical margin. His PSA had been he'd been offered to be on ADT, but he did not tolerate ADT very well. So they just monitored his PSA, and then his PSA started rising. They got a bone scan and a CT scan, which was negative, and then he enrolled in our PSMA study, which showed a small sternal lesion right here. And so from an IR perspective, this is kind of a fun case, because when I went to biopsy it, you saw there was no CT correlate at all. So you have to really base it off of where the MR is and where the lesion is. And so we biopsied his sternum, and came back positive for prostate cancer. So rather than being put on hormone therapy, he had targeted SBRT, and his PSA went down to back to his baseline, which was around 0.06. Second case was a gentleman who had been treated with high-risk prostate cancer with radiation. He had a rising PSA, which they were concerned about. He was restaged with a MRI, CT, bone scan, and he actually had an oxynium or fluciclovine scan as well, which were all negative. Part of, we have a prospective ablation trial at Cornell, and part of that includes PSMA pre-ablation. So he enrolled that, and unfortunately, prior to doing the procedure, as this PSMA MRI shows, you see some positive lymphadenopathy in the left side as well as the sacrum. So because of this, he was not a candidate for salvage cryoablation with this. And then PSMA really does change management, I think, and I think it will, because men that you probably would have normally treated with just ADT for presumed biochemical recurrence, now you have these oligomets that we can either treat with surgery, ablation, or targeted radiation therapy. And I think that that is kind of a new way of approaching men with prostate cancer, particularly metastatic cancer. And then these slides here just demonstrate that the accuracy of the PSMA is much better for compared to, say, the fluciclovine, because we can detect lesions when the PSA is less than 2. And this is also just demonstrates that there's wide variability as we would expect with positive PSMA scans. This next case was a 60-year-old male who we had been following for low-risk prostate cancer. He was on active surveillance starting in 2014. In a rising PSA, he got an MRI, which showed a lesion here, seen as this T2 hypointensity in the right peripheral zone, and this was targeted with a fusion biopsy as well as systemic, and it came back as a Gleason 7. We were part of the Insightec MR-guided focus ultrasound trial, so we enrolled him for this, and he underwent an in-bore HIFU procedure. And this is the immediate, this basically here is an axial image of the transrectal probe and ablation device, and this is a post-ablation contrast-enhanced scan. It's showing the area of no perfusion after we did the procedure, which was good. He was really worried about both urinary and sexual health, and at 2 years he had the same urinary and sexual health he had. We did a 2-year biopsy. This is what the MRI looks like 2 years after. You see that that area of ablation's retracted somewhat. The rectum's kind of tented a little bit. We did, again, another transperineal targeted biopsy within that area in the prostate cancer. He had no prostate cancer there, and as well as a systemic biopsy demonstrated that as well. So this was a good example of focal therapy for prostate cancer in someone who had progressed while on active surveillance.
Can you just tell us what's the difference between that focal therapy and HIFU?
So the difference between this and, so HIFU outside of the MR gantry basically uses ultrasound to guide the ablation. With this in the MRI machine, you're still using HIFU, but you're using MR thermometry to do your planning and then get feedback with regards to the ablation. So we do in-bore and out-of-bore, and I'm biased just because I've seen both. I think out-of-bore is less precise to a certain degree. I think that in-bore, really because there's that MR thermometry, you get a good evaluation of how well the thermal ablation was that you don't necessarily get with the out-of-bore HIFU device. It's similar to doing like a renal ablation. When you're doing the ablation of a kidney, you can scan intermittently either with ultrasound or CT, and you can see exactly where the ablation zone is. And there's just not, that doesn't exist with out-of-bore HIFU. With the exception of contrast-enhanced ultrasound, there's some data to suggest that's a good way to evaluate the ablation zone as well. So the index lesion hypothesis, this is really just kind of going over the where the idea of focal therapy is, and that is that the index lesion or the higher risk prostate cancer or higher grade prostate cancer is the one that will dictate pathology. And if we have time, I can go over at the end of the talk. I put those at the end of the slide, but I'm not sure we'll have time to go over it. But basically, in essence, what you do is there's an area of higher grade or higher volume prostate cancer. For example, in our previous patient, the area that progressed to Gleason 7. you ablate that with the technology, preserving the nerves and the urinary function, allowing the patient to remain having a good health-related quality of life while having good oncologic control. There's numerous ways to do this. There's cryoablation, which is the longest one that's been around. This is where you freeze thaw the prostate to kill the specific area. Cryoablation has some limitations in the sense that you need a much larger ablation zone compared to HIFU or IRE or these other technologies. HIFU or high intensity focused ultrasound uses focused ultrasound to deliver energy and cause destruction and thermal process with targeted therapies, and there's in-bore and out-bore technologies. Laser is another interest, particularly FLA. This has generally all been in-bore in the MR machine. There's a couple studies that have looked at out-of-bore ultrasound-guided FLA. The problem with this is that there's really no way to monitor the ablation at all that way. And if you look at the studies that look at FLA out-of-bore, the positive rate in the ablation zone approaches 80%. So you're not doing much with regards to treating. It's probably better done in the magnet. And then irreversible electroporation is where you deliver high voltage between the two needles, and that allows you to get cell necrosis because of cell lysis because of the disrupt the cellular membrane and osmolarity. This is disadvantage is you have to be under general anesthesia for this, and placing the needles can be a little bit tricky because they have to be exactly parallel to get the good voltage across the two. But this has been reportedly to have better outcomes with regards to sexual function.
Which HIFU, focal therapy do you not require anesthesia?
So FLA you don't, cryo you don't. And you can do it under local or MAC. I mean, most of them MAC. IRE you have to be paralyzed though, so you have to be intubated. I guess that's the difference. You have to be intubated. And then also the patient we were going to do, but he had a pacemaker, so you really can't use this technology with people who are paced. And then another one is vascular-targeted photodynamic therapy. That's where you get a photosensitizer IV, and then you have a needle placed transperineally, and then you turn on the laser, and that causes cell death that way. This again can be done under MAC. The outcomes for the issue with focal therapy is that there's really no randomized controlled trials or no great prospective trials looking at this. So this is why when you look at AUA guidelines, it's not considered treatment option for focal therapy. When you look at cryoablation, the longest follow-up you have looking at partial gland ablation is 37 months, and the shortest time is 6 months with IRE. And as we all know, prostate cancer is something that you look at decades to see outcomes. So this is really not great data for us if we're trying to push this field forward with focal ablation. With regards to ablation zone positive biopsy rates, it appears that cryo may be a little bit better. That might just be based because there's more studies from that. Some of these earlier studies, such as like BTP or IRE, sometimes are just a proof of concept to show that the technique is safe. So that's maybe why there's some differences in the positive ablation zones there. And then potency seems to be better with IRE compared to the other aspects, and then continence is good with all of these. But future directions, really we need more trials like this trial, which was Gill looked at vascular-targeted photodynamic therapy, and this was a randomized controlled trial where they compared the targeted therapy versus men on active surveillance. Their primary outcome was seeing if they would reduce the risk of progression, meaning that they would need some definitive therapy, and they showed that they did do that. I think it's up to us to come up with new similar studies, randomized controlled trials, maybe not necessarily looking at active surveillance, comparing it to surgery, but we need long-term data to address and answer the questions with regards to whether or not there's true oncologic control with that. And then which ablative technique is best? That's another big question that we have. Part of the limitation with the HIFU is that it's like taking a magnifying glass and burning a leaf. So you can only burn a leaf so far. So these anterior lesions are hard to get with HIFU. With cryoablation, you can get anterior lesions nicely, but you have to have a big margin. And so for a lesion or an area of prostate cancer that's right next to the neurovascular bundle, cryoablation is probably not ideal for that because you'll injure that nerve and cause worse potency. So kind of where the lesion is kind of will dictate therapy to a certain extent. This group suggested that for anterior lesions you use cryoablation, for peripheral posterior lesions you use HIFU, and for lesions near the sphincter you would use brachycedes. And the reason for that is because you can have issues with stricture if you get too anterior with either cryo or HIFU. And then another question we have to answer is, what's the post-ablation follow-up? There's no defined follow-up right now. There's no general consensus. We need to have a better understanding of who's the best patient to be selected for this. Sometimes in my office I'll see 55-year-old young healthy guys wanting focal therapy when that's probably not the best patient population. Those guys are probably better served by surgery. And it's also important to realize, or inform patients that once you've been treated with this, you're basically on active surveillance for life. And so they have to understand that they're going to be monitored and have to have repeat biopsy and things like that. And then we also need to have a better understanding of what imaging will look like after ablation and what it means if we see something abnormal there. This next case, so that's prostate cancer. Now we'll move on to benign prostate issues. So then this next case was a guy who I had seen for an elevated PSA with a anterior lesion with prior negative biopsies. So he came to me for a fusion biopsy, which we performed, which was negative, but part of my intake sheet is urinary function as well. As you can see here, his IPSS score was fairly poor, 24 with a quality of life of 4. He had tried meds and was unhappy with the medications and did not want a surgical treatment, so we elected to do a prostate artery embolization. And just an overview of what prostate artery embolization is where you get a small catheter, usually through the leg of the radial or femoral radial artery. We select the internal iliacs, then identify the prostatic artery, and then once we're in the prostatic artery, we then embolize it with usually endospheres is what I use, 300 to 500 micron beads, and then that causes ischemic necrosis and shrinking of the prostate. And this gentleman underwent PAE, and then at about a year and a half afterwards, his symptoms had improved significantly. His IPSS score was a 4, and his quality of life was delighted. So what is prostate artery embolization? Well, it was first reported by Dr. Demerit when they reported on 2 cases for refractory hematuria where they did prostate artery embolization with PVA particles, and the hematuria stopped, but they also noted that their IPSS symptoms improved as well. And that was 2000, and then about 8 years later, the 2 pioneers in PA was Carnevale, who reported on 2 patients where they did prostate artery embolization specifically for patients with LUTS, as well as Pisco, who reported on 15 patients with PA for LUTS, and they showed good improvement in symptoms with that. So based on these 2 studies, there's been several randomized control trials which have looked at prostate artery embolization. The first one was from Weill. This was a randomized control trial with 57 patients in the TURP arm and the PAE arm. And what they found was that at 6 months, IPSS scores improved similarly to that of TURP, as well as quality of life and PVR. One of the issues with this trial is that a critique was that in the PAE group there was a much higher complication rate compared to the TURP group. But I think that's in large part because they include major overall adverse effects, which were major complications as clinical failures. So to me, a clinical failure isn't necessarily a complication. So this study showed that at 2 years, TURP was similar to PAE. The limitation that some of the urologists will say is the fact that it has a higher complication rate. I think that's really not the case because these the study included failures as complications. The second study was done by Carnevale in 2016, and this was, the study itself is a little convoluted because they have 3 groups. It started out as a randomized controlled trial between TURP and PAE, and what they found was that PAE did not improve the IPS scores as much as they thought. So this is where Carnevale came up with a perfected technique, which is where most of us are. That's the way we embolize prostate. So you'll embolize first proximally, and then you'll get the catheter deeper into the prostate and then embolize subsequent to that. And the randomized control part was this. The non-randomized comparison was this. So if you look at the perfected technique, this is similar to TURP, but you have to realize that that was just a retrospective comparison, not the actual randomized control. So when you look at Carnevale's study, it really shows that TURP is better than PAE. And then Carnevale also showed that there were kind of expected effects if you have some non-target embolization, rectal bleeding from getting some non-embolization to the middle rectal, some pubic bone ischemia, as well as some transient hematuria from the inferior vesicle. And then all the TURP patients had, expected post-op frequency urgency. Some needed transfusions, and there was a fair amount of incontinence as well after this study. The issue with the Carnevale study, small sample size, only 15 patients in each arm, and a randomized control trial that was part of it really showed that PA was inferior to that of TURP. The most recent study was from APT, and they looked at about 50 patients, and they compared PAE to TURP. And what they found was that at 3 months, there was no difference in the outcomes between the two, but they couldn't prove that PAE was non-inferior because there was too much variation with regards to the IPSS improvement with the PAE arm. And I think that's in part for 2 reasons. One is the follow-up was 12 weeks. So we saw in the Gauss study that the improvement was seen best at 6 months. So you see a majority of my patients will have a notable symptom improvement by about a month or 3 months, but that continues to get better till about 6 months. And then the other thing was they used a lot of the prostate gland size was less than 60 grams. So that's kind of considered small prostate if you're doing something less than 60 grams. The other thing is, I think this is more realistic, is that the adverse events were more common with TURP, and that's what we would expect. So TURP had about 2 times more complications than the PAE arm.
How did they QA all surgery trials are challenged in terms of who's doing the operation? We all know the TURP, the amount of resection varies according to who's doing it. So was that a single surgery, single surgeon TURP? How were they QA?
That was single surgery. You bring up a good point. So the next study is the rope study, which addresses that, because the rope study was so the app study was a single group. The rope study looked at the United Kingdom, and they had a registry of multiple centers, and I think this is more realistic of what you'd see in real world, because it's real world operators with limited experience. And what they found was that the improvement that you see with the PAE was not as drastic as what you'd see with TURP. And the improvement in TURP was 15 points, whereas the improvement with PAE was 10 points. I think this is more kind of realistic of what you would see in as PAE is implemented. Because in the UK, the NICE says that PAE is an option for that. And the other important thing is PAE shows that 20% of the patients undergoing PAE, there's a 20% failure or need for retreatment with that compared to the TURP. So I think the UK rope study is probably the best study to give us that real-world perspective of when you implement this technique in managing patients with BPH or LUTS secondary to BPH.
If you're starting out with your experience with PAE, when do you recommend follow-up imaging to look for volume reduction?
Well, I don't do it unless I'm worried about a rising PSA, because you don't do it. I base it off of symptoms. Because if you do a TURP, you don't get an MRI or an ultrasound after to see.
Yeah, any PSA data?
The PSA data that shows it is that there's a small improve or reduction in it, but it's not significant, and that's part of the concern, is that we may be treating, basically temporizing these patients with symptom improvement where they might need another improvement or another treatment in 5 or 6 years. Pisco had, I think he had 600 patients recently that was published. That was all retrospective though, and at 6, was it 1,000? Yes. I think what he considered like success rate was about 85%.
Because, like where I see this, and we've done a number of cases here, but it's often sort of, I call it the Goldenberg patient, but it's like these younger guys that are fixated on their potency and worried about continence, and they've got huge prostates, and when you appropriately counsel them about a whole up or a TURP, et cetera, they're just not going to go down that route. They don't want to be in medical management, and it may be trading land for time, and that you're basically, you're going to get 5 to 10 years out of it, and then they'll be back. So we noted symptom reduction, but not much in the way of volume reduction. And then I had one case recently where the patient had 2 embos done in Edmonton, and I think they probably were pretty competent in terms of the procedure. And when I did the whole, I took about 200 grams of it, it's like nothing had been done to the transition zone.
Yeah, I don't think you're getting much. It depends. If you look at the literature, they'll say the reduction is anywhere from 30 to 50%. I think that might be overestimating it a little bit. But from my perspective, to a certain extent, you can view this as maximal medical therapy for these guys without having to deal with the side effects or having to take a pill every day. And if it buys a man 5 or 10 years, doing this doesn't prevent you from doing a subsequent treatment. So I think in that aspect, it's a good option for men. And there's been a lot of concern about the complications related to PAE, like non-target embolization, but I think that risk is exceedingly low when you actually look at real world, because we now have great techniques to identify the prostatic artery and confirm that we are actually in the prostatic artery, so we don't have those non-target embolizations. So despite multidisciplinary or multi-society and international acceptance, I was part of the SAR panel that wrote the position statement on PA. We endorse it. NICE endorses it. The AUA does not. They still view it experimental and recommend it to be in a clinical trial. So because of that, at Cornell, we have a prospective observational study looking at PA with LUTS secondary to BPH. And I think that's just one step that we have to do to show that this is, or convince our urology colleagues that it's a good treatment option for some men.
Is that sufficient?
Probably.
Randomized.
No, you got to do more.
Randomized trial, right?
Yeah, you need randomized controlled trials, but there are. Yeah. You probably need. Yeah. I think where PA may have a role though is with cancer, and the reason why, when you look at liver cancer, TASTE is an approach we manage men with HCC, and there may, from a focal treatment perspective, embolization could offer some great treatments and allow you to treat the multifocality of prostate cancer. There's been 2 studies that have really looked at this. One looked at bland prostate artery embolization in patients preoperatively who subsequently had a prostatectomy. They looked at 12 men with prostate cancer. PA was performed with 100 micron embosine microspheres. And then they looked at the response to tissue with regards to seeing any cancer cells. So there was, it's listed here, tumor regression grades they rated as 1, 2, and 3, where a 1 grade was complete response, 2 was some response, and 3 was really no response. And what they found when they looked at the histology was the prostatic areas showed areas of fibrosis and necrosis, which is what you would expect with ischemic necrosis. And not surprisingly, the ischemia is more pronounced in the central gland versus the peripheral zone. So when you're doing these procedures, you see the prostatic artery, particularly in these big prostates, the adenoma in the central zone is much more prominent. Sometimes that's the dominant one. And then there was no evidence of ischemic damage to the neurovascular bundles, but they did see endospheres throughout the prostate and the seminal vesicle. Complete necrosis was seen in 2 patients. Partial necrosis was seen in about 40% of patients, and 10 patients had no response, and they had secondary foci throughout. And this is looking at the index lesion.
But that's not
complete.
P0.
No, not P. It's just looking at like what they presume the index lesion was from that. So there's still cancer there. Then the other study that looked at was from Pisco, who unfortunately passed away this year. But his study wasn't great. I think it was poorly designed, to be honest with you, because they basically embolized it with this mother tincture chemical and then doxytaxol, and then just did a bland embolization after. And they only defined success as a PSA rise greater than 2 nanograms, so there was no biopsy data at all. So this was a poorly designed study, but something like this could be done, I think, for looking at patients, particularly with, and they defined biochemical success at 82% at 18 months, but again, no pathologic proof that this did anything. So PA for prostate cancer, potentially, I think there's some things that we could potentially capitalize off of the fact that we can get drugs delivered where we want to very specifically, and it'd be a truly minimally invasive focal treatment for prostate. All right, now we're going to move to kidney. Do I have time? No? 5 minutes? All right, we'll blow through these because this is really just about education. So, kidney biopsy. It's something that we do. This was a woman who had CLL and a small renal mass. I did a renal biopsy and it came back oncocytoma. So that we relieved her stress that this was a renal cell carcinoma. I think renal mass biopsy is really underutilized. This was John Leppert, when he was a resident at UCLA, suggested that the use of renal biopsy was increasing. However, Jim Hu and I looked at recently at a SEER database from 2004 to 2013. We found that the use of biopsy was only 8% with patients getting a nephrectomy, and Leppert found that was to be 12%, so it seemed like the numbers were going down. And then in patients who were getting ablation, the biopsy was horrible. It was at 50%. So all guidelines with ablation suggest that you have a biopsy first. So it's really bad that 50% of patients aren't getting biopsied on ablations, because we need to know how to follow these and we need to know what we're treating. Part of the reason why it's not being done is, I think, education. There's still this belief that there's tract seeding, which is really not existent in the way we do it today. Risk of bleeding, I think, is also very, very low. And also the thought that it will not change management. When you talk to patients about this, when you tell them that this is a benign tumor, oftentimes they're much more comfortable just proceeding with surveillance or just getting an ultrasound every other year rather than undergoing a partial nephrectomy. So I think, and this is a study that was actually in this month's JU that showed at University of Wisconsin, they did about 1,155 consecutive percutaneous biopsies, and they showed it's very safe, very small major complications. There was some non-diagnosis of about 10%. I think that might be in part because they're not getting a big core number. Usually if I do a biopsy, I'll get 4 to 6 cores, not 2. So I think that the numbers can be higher if you get more core samples. And I think you can do more core samples without having a big risk for bleeding. So the future direction for renal mass biopsy is education. We need it. Second case was just renal ablation. Basically, ASCO, Canadian Urologic Association, AUA, all recommend renal ablation as an option. They really only discuss radiofrequency ablation and cryoablation. This was this was this month's paper that showed that partial nephrectomy versus ablation has similar local recurrence survival and cancer-specific survival at 5 years. This was the Mayo Clinic's group. So it really is on par, particularly for lesions less than 3 centimeters. This is a Garvey's group, which is highlighting that fact that for lesions greater than 4 centimeters to greater than 3 centimeters, the success rate is much less. So from an ablation perspective, there's 2 things we want to do. Is how can we make ablation more effective and new evolving techniques. I think microwave ablation is much faster and more effective than radiofrequency ablation, and it's I think it will replace radiofrequency ablation. In the interest of time, and then IRE may be an option for patients with hilar lesions or lesions close to the collecting system. And then MR-guided laser therapy. There was a poster at AUA 2 years ago that suggested that you can have no effective heat sink with the laser ablation, but this is in-bore, so I think this may be an option to manage some of these smaller lesions that are next to the renal vein or artery. So future directions for ablation will be kind of figuring out what ablative techniques will be used, and I think microwave is replacing RFA. I'm not sure what you guys do here, but I use microwave. And then one of the limitations is the renal mass greater than 3 centimeters. I think embolization with ablation is a way to come up with this. This was a gentleman who had a 5-center renal mass. I brought him to the angio suite, embolized his renal mass, and then ablated him that same day. And then a year follow-up, the lesion was treated, no evidence of recurrence was there. So I think there's combined endovascular and percutaneous approaches that we can develop to really optimize kidney ablation. And then the last 10 cases, just again, education. This was a 41-year-old woman, Canadian, whose brother had a renal mass he had a nephrectomy for an angiomyolipoma. And then she had this growing right renal mass, and she was told it was cancer and needed a nephrectomy as well. So she sought a second opinion. I recommended embolization. So we did an angiogram. You can see the AML here. And then selected the tumor itself. Embolized, and then at 6-month follow-up, this was the lesion before. Right here. Oh, that's post, sorry, I got it. So that's what the lesion will. Let me do the next slide. Sorry. Videos are throwing me off. I biopsied the first, yeah. It was AML. Yeah. So that was the pre, and that's the post. This is from the Journal of Urology, kind of AML Management. I really don't think surgery should be involved with these tumors unless they're huge. I think embolization or percutaneous ablation has a good role for these patients. And again, education. So I think for kidney stuff, a lot of it is just education. Any questions?